Okay, welcome everyone to our afternoon panel session on how can investors and payers contribute to technology and development at home. So we have quite an esteemed panel today. I'm excited for this discussion, and I will be your moderator today. I am Kim Sciarretta, and I'm the branch chief of the launch office in BARDA Drive. So I just have a few slides here to just level set for the discussion today. And just wanted to highlight, and we've heard this throughout the meeting, that a key opportunity to intervene in a patient's care journey is really in this pre-hospital or at-home space. And this was truly exemplified during COVID-19, where we saw so many people with mild illness, but there was a question about whether they would succumb to severe illness. And so there was a need to monitor a large population of individuals in a setting that wasn't at the hospital. But we also know this from sepsis as well, where the majority of cases, it can be as high as 85% and even higher in the Medicare population. Sepsis arises in the community, not in the hospital, in that percentage of individuals. So it's important to be able to understand that your health status in these settings that are in this pre-hospital or at-home setting. And so we've seen this shift to this care at home, but technology is driving that too. And really, this was all commanded by COVID-19. The telehealth medicine, the telehealth market's now exploding, but more individuals and patients are feeling more comfortable using that type of technology and engaging with their healthcare providers over the phone or through apps. And then we're seeing healthcare systems and hospitals also adopt this practice as well with the use of telemedicine. But patients are also shifting away from that hospital-based care or outpatient care. It's not just because some hospitals are closing, but it's also because patients want to be in more control of their health, where they seek care when they want it and where they want it. And they're more comfortable going to retail clinics or outpatient retail clinics or other sort of pop-up clinics for care, or even stay in the comfort of their own home. And many Americans don't even have that primary care physician. So it's nice to be able to access your health care again at your convenience. And many of these technologies are now accessible to us. Many of us have these wellness monitors, and there are more technologies now available that can not just monitor wellness, but also your health and perform diagnostic care. So although we have these diverse set of technologies available, everything from, as I was mentioning before, these physiological vital sign monitors to diagnostic tests measuring your urine or conducting endoscopies, or even, the pathogen-based diagnostics like the over-the-counter COVID test that we all have at our own homes. Even though we've been using these, it's difficult to assess the value sometimes. And so, but this is a job of investors and payers and regulators. And that's who we're going to tap into to get their perspective today. And just to touch on a few points that you'll probably hear come up in the conversation today, this the value may be affected by, are we targeting the right patient with these technologies? Are we targeting them in the right setting? What is the market potential for these types of population or these types of technologies? What is the potential return on investment? And is there a difference when we consider a wellness tool versus a regulated tool? So with that, I would like to just briefly introduce the panelists, and then we'll turn over to them. So we'll have Dr. Mona Siddiqui, who's the Senior Vice President with Clinical Operations at Humana Home Solutions, so you'll get the payer perspective. Bruce Greenstein, who's the Executive Vice President, Chief Strategy and Innovation Officer with LHC Group. And this is a home health company, and he navigates between the users and the payers, and so you'll have that perspective. We have Dr. Bill Padula, who's the Assistant Professor of Pharmaceutical and Health Economics at USC, and he's actually conducted some of these economic analyses of use of some of these tools. So we'll get his perspective. We have Dr. Arti Tandon, a digital health specialist with FDA CDRH. So that's your regulatory perspective. And then we have Dr. Damien Soghoian with who's a partner with GHIC, and this is BARDA Drive's venture partner. So you'll get the investor perspective. So with that, I will turn over to our panelists for a brief introduction and for them to share a little bit about their experiences with at-home technology. So we'll start with Bruce.
Hey, good afternoon, and thanks for having me here. I'm going to take these 3 minutes and just talk about what we see as the benefits, the challenges, and the future of using this kind of technology in the home. And we provide home health. Most of it is post-acute, so these patients are coming home from a hospitalization. And at any given time, we have about 100,000 patients on census. So we've tried through our own pilots and programs many different ways of using technology at home to help monitor the patients. We love it. Basically, we think it's a great opportunity to manage and monitor high-risk patients, avoiding ED use and rehospitalizations. We use it as an integral part of many of our clinical programs that is part of our overall care plan. Think CHF, diabetes, COPD. We use it as a way to prompt our patients to be adherent on care plan, whether it's around medication reminders, could be on the therapy side. And that to us is important. We also use it as a vehicle to produce education. And we also use it as the backbone of new programming. So think Sniff at Home is a good example of a new program that utilizes this technology, though it still has challenges. To start with, we have our patients between 30 and 60 days. This is a lot of technology to get set up, to get used to, and then make it a part of patients' daily habits as they're recovering from a hospitalization. And there's no business model. There's no additional payment associated with it. So we're using it primarily as a way to manage costs elsewhere. And it also has the tricky piece that it depends on people. Nurses set it up and patients have to take action to do something. What we'd like to see in the future is a much more passive environment. So whether it's around wearables, stickers, watches, we want to see battery life last a lot longer. We'd like to have devices that are completely passive and not attached to the patient to be able to collect most of the same information. And we also think that full EMR integration is really important, so it functions within the workflow of the clinicians. And then lastly, we see a big opportunity to be able to integrate this type of information to be shared among the family and caregivers in the household, rather than just the relationship between the formal caregiver and the patient. Back to you.
Thank you. And we'll turn over to Dr. Padula next.
Thanks for having me. It's a pleasure to share some insights from the health economic side of this scenario with monitoring at home. And I'll share with you just a little bit of background on a study that colleagues and I recently completed and ended up publishing on the health economics of pulse oximetry monitoring during the height of the COVID-19 pandemic in 2020. I, along with medical directors at university hospitals in Ohio, which is an accountable care organization, looked at a model that they had implemented where obviously volumes of COVID were really high. You had many people coming into the emergency department. And what ended up happening during the height of the pandemic, many of you will remember, is there were more patients coming in with COVID that had serious symptoms than there were beds in the hospital. And what university hospitals in Cleveland ended up doing as a result was partnering with a manufacturer of pulse ox monitors and putting these on patients' hands and sending them home, and creating a central command center to monitor these patients remotely for their pulse ox levels. And those patients with escalating severity of symptoms related to pulse ox and COVID were then brought back into the hospital when, especially when a bed became available. What we learned from this, and especially looking at this from the standpoint of an ACO, is think about it this way. A health system during COVID was obviously incentivized by hospitalizing COVID patients because they were guaranteed paid for by the federal government. That being said, if you don't have any more beds to give and you're an ACO, you're responsible for that patient, whether they're in the population or whether they're in the hospital. And so UH hospitals took it upon itself to invest in this infrastructure in order to manage COVID levels across the community. When we looked at these outcomes, we saw that there were two important statistics that came out of this whole model. That there was 87% fewer hospitalizations as a result. That many of these COVID patients who came into the emergency department who felt like they were having severe symptoms actually were quite manageable and they were getting better rather than getting worse. And there were even 77% fewer deaths in the total population as a result if you were to do a pre-post comparison of patients in the community around Cleveland. It's no surprise that this model of putting pulse ox monitors on patients, of setting up a command station at the health center, and hiring nurses and physicians to monitor 40 or more pulse ox monitors on patients at a time from home health, it was cost effective. And when we think about cost effectiveness, I want to point out that cost effectiveness really or the analysis of cost effectiveness represents opportunity costs, or to phrase it differently, the cost of the next best alternative. Keeping a patient safely at home where they're less stressed out, where they're able to comfortably, hopefully, recuperate from COVID-19 is a much better deal for our society than putting them in a hospital bed, spending thousands of dollars a day. Makes the patient nervous, uncomfortable, and they may get better instead, or sorry, they may get worse instead of better in that time frame just because of all the stress of being there. So we reduce opportunity costs on the whole as a result of keeping patients safely at home, whether it's COVID or probably a lot of other solutions that people are thinking about here today. That being said, there's an enormous investment in our infrastructure to change it, to monitor these patients up front. And we saw that at university hospitals where it was thousands of dollars to create a command center and hire FTE nurses and physicians to monitor these patients. So what I'll get at during the course of our discussion on this panel is just thinking about selling these ideas of managing patients from home is about not just the cost effectiveness or the value of these solutions, but how much return on investment is there? Because to a hospital CEO or CFO, they have to put that money up front to get patients over the hill of managing population health. And that's expensive, but in the long run, they should recuperate their investment, hopefully. And also to payers, like on the panel here, thinking about what could the budget impact potentially be to them? And if the payer in this case is the federal government, which was managing cost of COVID, you have to look at it from an advantageous standpoint of they had fewer hospital bills that they had to pay for, and the patients are healthier as a result. So this was a great example in our study of a win-win-win for the patient, for providers, and payers and decision makers, that they were able to, in the long run, recoup costs and achieve better health outcomes. So I'll leave it there and happy to explain a little bit more in depth about these economic statistics that come into play with decision makers and home health implementation.
Yeah, thank you. Hopefully we'll have a chance to dive into that a little bit with the discussion. Okay, I'll turn over to Dr. Siddiqui.
Great, thank you. And thank you for including me in the discussion today. I think Bruce and Bill set it up well. I want to just step back and say, I think part of the reason why we're having this conversation is because all of us fundamentally believe that more care should be delivered in home and community-based settings, right? So I think that's sort of the starting premise. I think it's how I would want to age. I think it's how I would want my parents to age, to be able to have as many services that are centered around the individual rather than centered around a brick and mortar facility that an individual has to go to. So I think we're all agreed on that premise. The question is, how do you make that work in a way that is a seamless experience for the patient, a good experience for the clinician that's going into the home, and for the family and the caregiver that's involved as well. And technology has to be, I think, a part of that solution. I think what's been challenging, and Bill alluded to this a little bit, is what technologies for whom and when, and how do we make sure that they're cost effective, they're deployed in a way that doesn't feel like it's an interference for the patient, that it feels like it's part of their caring system around them. Oftentimes the things that patients have to deal with feel like an extra thing that they have to do, and another gadget that's in their house that they have to try and handle And so how do we make sure that we create that more seamless experience for the patient? How do we make sure that there isn't a burden on the clinicians that have to navigate, as Bruce said, so much of the implementation up front? What do we need to do to make sure that the data that we're getting, that we're able to differentiate the signal from the noise, which I think has been a challenge? How do we train our workforce to be able to look at information and make decisions in a more timely way than they've had to do in the past, right? There's an enormous amount of information that's coming at them. How do we help in really making sure that they're looking at the right information at the right time? And then, I think how do we? I think Bruce said this. How do we connect the infrastructure? So from the patient's home to what the clinician that's going into the home is seeing, to what gets inputted into a patient's record, and that piece, which is a place where not a lot of people want to spend time on, but how do you create the right infrastructure so that becomes a seamless part of the care for that patient is also important. I think to what Bill alluded, it's a really important conversation to have around how do you target the right things to the right patient and really make the business case, because we are still in what I would say are still some of the early innings for deploying remote monitoring technology in really effective ways. And for those of us who are in those positions to implement those in our organizations, you have to make a really compelling business case, and you have to make sure that at the end of all of that implementation, that there's a return on the investment that you're putting in. There's no doubt in my mind that this is going to have to be a part of the solution. But how do we work in a way to make sure that the investments are really yielding the returns that we need, both from a financial perspective, but more importantly, preventing the clinical events that we're trying to prevent in terms of patients going back into the hospital. So looking forward to the conversation, and I think we have a varied number of perspectives included, so looking forward to it.
Thank you, Dr. Siddiqui, and I appreciate you kind of taking us back to the fact that this is what we all want, and so it's a balance, and it's good to have these types of conversations to understand all the factors at play here. So I'll turn over to Dr. Tandon at FDA.
Good afternoon, everybody, and thanks for including me. And great to hear all these different perspectives. I think from CDRH's perspective, advancing health technologies is one of our strategic priorities, and we believe that there's a promise of digital health technology, how it can enable really meeting, like what we all discussing, meeting the patients where they are, whether it be home, and also thinking the urban or the rural environment, wherever they might be. And how you can use these kind of technologies to facilitate also, the participation of all the communities, all the populations in clinical trials, and also use them to collect public health data. So, these are kind of some of the priorities that are important to us. And I think there are a number, and Kimberly, you showed us a number of great examples from that of devices that have, regulated devices that we have. And I'd like to point out, from our perspective, our focus is, how do we get many more of these out that are safe and effective to use? And besides, some of the examples that you showed, I think I would like to highlight a couple others, which are important maybe for this audience. For example, we have a virtual reality behavioral therapy device for pain relief, which can be, used where you can use virtual reality display to give the therapy for the patient at home. Then you have digital therapeutics, which can help with reducing sleep disturbance for psychiatric conditions for patients who have this, for example, due to PTSD, by providing, stimulation to the patient using a general purpose platform. We have real-time continuous glucose monitoring, which can be used for diabetes management. And the interesting thing about some of these are that they can be connected to other devices, to provide kind of a seamless experience to the patient. And of course, the over-the-counter hearing aids that was highlighted by President Biden in his State of the Union address. So as you can see from these examples, the regulated devices, there's a whole spectrum going from diagnostics to monitoring to digital therapeutics. for over-the-counter use or for prescription device. And I think some of the challenges that we see from a regulatory perspective is, the developers need to really demonstrate they've done adequate performance testing, verification, and validation to show that these devices are safe and effective to use based on the indications for use. And I think the other thing at home, when you think about at-home usability and user comprehension, is really important. That the applications are developed so that they are developed to mitigate the health and technology literacy differences that will inevitably be there with the users. Do the users know, because we anticipate more upgrades, do they know who do you contact? How do you do your upgrade? Who to contact when you have issues with your device? Really thinking about easy to use, making the results clinically interpretable, easily interpretable, thinking about the risk and benefits of false positive versus false negative, going to the point that everybody's talking about healthcare utilization, how does, going through that whole thought process to thinking, what does it mean? And I think the other thing that we like to encourage is using the technology, not just, of course, there's the monitoring of the patients, but monitoring the product also to see, are there any issues that you can identify earlier? And, how you can then make sure you have your real world monitoring as well as, thinking about how to improve the product earlier than later. So looking forward to the discussion. And, I think it's a really great panel to be part of.
Thank you, and thanks for highlighting some of the challenges too that exist with bringing products forward from the regulatory perspective, and then also not just once they're once they're approved, it's still that adoption piece that we need to figure out. And I think we'll be able to get into that, but I want to make sure we get to Dr. Soghoian to give his introduction next.
Thanks, Kim. So as Kim mentioned, GHIC is BARDA's venture partner for this very unique public-private partnership that we have to use venture investments to support BARDA's mission, which is catalyzing innovation in the space of medical countermeasure technologies. So everything we do at GHIC, we do through the lens of how might this influence our posture in the event of a public health emergency, or allow us to be more proactive in preventing a public health emergency. I'll do my best to try to represent the sort of generic investor view as well, but that's how we think about these technologies. And when it comes to the lens of health security and at home, Kim mentioned a lot of the things that we think about. A lot of these were driven by COVID, which really caused this whole area to explode. So on the acute public health emergency side, we really think about what are the technologies that let us react faster. So this is often monitoring and diagnostics, but it could be on the care pathway side as well. And we have some really great tools now that were developed before the pandemic, during the pandemic, but we're always on the lookout for the next generation of these tools and technologies. The other really important area in the event of a public health emergency is just keeping the burden on the healthcare system lower. So we really like to think about what are the technologies that are going to keep people out of clinical settings that might be really important for responding to the higher acuity cases in the event of a public health emergency. And then the last thing we think about is what are the non-emergency uses that are going to drive adoption of these technologies, so that the footprint, the installed base, the familiarity of the patient population, the consumer population is all really high, so that if something were to occur, we already have the infrastructure in place to spin up better reaction at home.
Thanks. So let's get into a little bit of the discussion, and I want to jump to this piece about how we evaluate the economic benefit of these at-home technologies. And I think there were a couple points brought up here, not just how you do that type of study or what goes into that analysis, but when is the right time in product development to do that, or in use of a product to do that? economic analysis, but also with what Damien mentioned too, how do we weigh the effect of a pandemic, right? An analysis of these tools for their long-term value. And I think, Mona, you had mentioned a little bit about this too, of separating the signal from the noise, right? And I think the pandemic, everybody was forced to be at home all of a sudden, right? So we were highly reliant on these types of tools, but is the dust going to settle? Is that going to be a continuing trend? So how do you conduct that type of economic analysis? So we haven't heard from Bruce in a bit since he was our first one. So I'll turn it back to him for his perspective on this.
Well, great. So the way that we look at trying to come up with a model to determine if it's cost effective or not is it saving money somewhere else, or is it making money? And in our case, again, we don't bill for services that are associated with the technology. So we're going to try to make a win out of this with an ROI in either two ways. One is we're in value-based relationships, and by having some preferred outcome, like lower utilization inappropriately of the emergency department or having fewer patients go back to the hospital, we'll end up doing better. And we believe these technologies can help us get to that point. The other is to do some type of either substitution or a downward push on the labor side. So be able to do visits virtually rather than having nurses driving around. We'll have a nurse, either the same nurse or a centralized bank of nurses, do visits in some more coordinated, more efficient manner rather than going individually to the home. Those are the two essential models that you have to figure out what to do. Now, if that were the only case, I think this would be quite easy for our industry, but the targeting aspect is not. So as I mentioned, we have about 100,000 patients on census today. Not every patient is high risk. Not every patient's really at risk for going back to the hospital in the next, say, 11 days or 30 days. And so patient selection is critical, because if you really need it for 27% of your patients and you put 50% of your patients, you're never going to end up with a positive ROI. The costs are just too high. So that's the conventional model today on how we do it. Until the cost of the technology, the logistics, the bringing it back, wiping it, both physically and from a data perspective, until that marginal costs come very, very low, you're going to see very selective adoption of the utilization of these technologies, or you'll see a complete, a no vote and just go back to more traditional means of providing care.
So you mentioned an interesting point is how the caretaker is involved in this, or healthcare providers in use of these technologies in the at-home. Do you think the onus is more on the developer to be considering that up front, or is it really more about the patient population? I mean, where do you begin to have that conversation of that added cost that comes into play there?
Yeah, there's probably three zones. One is in the regulatory side in terms of how is data, health information shared between the patient and someone other than the caregiver, in this case, the clinician. And that's a bit tricky. Now, it's possible to do, but it takes time and effort, and to get attestations and have the patient elect to share information more broadly and then document it and keep it is not a trivial matter. It's both serious, and it just takes time. And that time is usually taken away from more clinical matters, and instead you're spending it on, issues that are administrative. The next piece is really the family itself. So that means somebody has to look at the information. Is it just sharing that they're seeing a duplicate copy of what is going to clinicians or those that are really monitoring the patient? They could be having an exacerbation of some issue. Or are there false alarms, or is it just, monitoring when a patient goes up the stairs and heart rate goes up, but then it comes back down afterwards, and there could be an overreaction. And then the last piece is around the technology itself. That is really the solutions that we see on the market have not been developed with the eye towards sharing information to an informal group, whether it's to maybe the spouse or the adult kids, or to neighbors, the mailman, however kind of care is thought of in that very micro community. We haven't seen that kind of technology that irons out the two issues, regulatory and the logistics piece. But listen, we would invite it. It makes incredible sense. And in the use case that I'm giving on home health, it's tricky for a variety of regulatory and time-bound reasons. But when we think about just the massive scale necessary of caring for the baby boomers to stay in their home a lot longer than they would otherwise be able to, I think the notion of bringing that care team together tighter, informal supports, familiar supports, and be able to have some information that can be shared formally with their clinicians, whether it's a primary care physician or it could be an ACO that's doing pop health. That really has to be a focus for the future in development.
Thank you. Mona, do you have anything to add from your perspective with a payer?
Yeah, I think again, just to step back, Humana acquired a home health company and made some significant investments in urgent care and primary care in the home about 5 years ago. So why would we do that, right? We are primarily a Medicare Advantage plan. Our members are with us for an average of 7-8 years. So our incentives really are aligned to with the members' incentives in enabling them to stay in home and healthy, and to really invest in efforts that allow us to keep those members in their home and community-based settings. And so when we think about, making further investments in more care in the home, technology has to be a part of it. To your question, Kim, around when do you start to think about looking at the economic model? You look at the economic model right up front. Because if you don't, you waste the partner's time, you waste the payer's time, you waste the patient's time, frankly. And you look at a few opportunities for value creation, right? It's either in preventing ED admissions, it's preventing inpatient admissions. It could be to do additional things that we want to do for those patients in terms of preventive care in the home, close gaps in care, and do more chronic care management for those patients. So there are a few different opportunities for the things that you can improve from an outcomes orientation. And so you look at, what is the opportunity to be able to impact those outcomes versus the cost of the technology that you have to deploy, and not just the cost of the technology, but the cost of implementation, the cost of training, and the cost of not doing something else that frankly that you could be doing. And then you look at the number of patients that you think about the proportion of patients that you can impact and the percent by which you might be able to impact. And you do that math up front to say, okay, if this costs me $200 per patient, and I think I might be able to impact X number of patients and improve outcomes by X percentage, does the math actually work? What number of patients actually have to accept that technology, have to actually be adherent to that for us to be able to see the impact that we want to see? From my perspective, for any company that wants to partner with a Humana or another company that's looking at the implementation, you want to do that economic analysis up front. And you don't want to be in a situation where you're doing it at the tail end or at some point in the middle of the implementation, and then realize that you have spent an enormous amount of time, energy, and resources and money. And you won't be able, you're not set up, or you're not designed in a way to be actually able to detect any impact on patient outcomes. So that becomes incredibly important. And frankly, like if we don't have a going in a sort of high likelihood of impact, I think it you have to really think about where are you spending your resources more effectively to be able to prevent those admissions and ED visits.
All right, thank you. Bill, so you're the economist here. I'm curious on your perspective, and maybe we can sort of pivot this conversation a little bit to talk about the difference between tools that are regulated versus wellness tools, and how that affects the analyses that you're conducting.
Absolutely. Well, I first want to just piggyback on what Dr. Siddiqui just said, which is absolutely right to do these models, these economic models, early and often. What the pharmaceutical industry does is they begin to build these cost effectiveness analyses before they've even run clinical trials. And it begins to create a conversation between manufacturers and payers to understand where there's value in implementing across different compartments of the healthcare delivery system. So as you get through the process of collecting data on safety and efficacy, that would be going to Dr. Tandon at the FDA, you can simultaneously be updating your value proposition and narrow down who's going to pay for this. And I think that is an important piece here to address your question with, Kim, which is, we have Medicare Part D. So for instance, so we have a way to figure out how our drug's going to be paid for in the United States. But when we're talking about these home health biomedical, mostly technologies, it was easy during COVID to say we have an emergency, we have to pay for this stuff. But what is the long run potential of implementing home health technologies and getting people to pay for them? It's going to require continually doing these economic evaluations and then finding out who is the value pertinent to, because like I said before, to the patient, it's minimizing out-of-pocket costs. To the provider, it's getting over the hump of a return on investment for what they have to institute in their local health system and their community. And for the payer, it's minimizing budget impact. You might not have all three of those scenarios pointing in the same direction. And as I said before, to the society, it's cost effectiveness or cost benefit, reducing opportunity costs. So finding out which of those different economic statistics hold a good margin for a stakeholder, and then working directly with that stakeholder, the provider, or convincing the patient it's worth buying it over the counter directly, or convincing a payer to co-invest in reimbursement of these technologies. That's, I think, what ultimately helps us to sustain a model of home health in the future when we're not in an emergent situation, as Damien put it.
Thank you. So Arti, could you add anything here regarding this balance of a wellness or over-the-counter tool versus something that's regulated?
Yeah, sure. I mean, first of all, we don't really look at the general wellness devices. We are not, examining them to determine if because they're considered low risk. So we kind of, we don't look at whether they're complying with, pre-market review or post-market requirements. And we have kind of two kinds of general wellness categories. One is, where you can make a general wellness claim not linked to a disease. And then you have the higher category, which is again, general wellness, where you have some kind of evidence which says, okay, these kind of healthy lifestyle choices can improve the management of this disease or condition. So in short, general wellness is not something we consider at low risk. We are not looking to, regulate those. And we encourage sponsors to really come in and, if they have questions, is this going to be regulated or not? We have help desk, an informal way to contacting us. And we encourage developers to come in as early as possible, when they are part of their development journey. And, I'll just put a plug in for it. It's digital health at fda.hhs.gov. We also released a software tool called Digital Health Policy Navigator, which developers, they can go in. It has a series of steps that helps you navigate based on the kind of product you have, whether their software functions, whether they would, potentially be regulated or not. So again, we encourage folks to go and use that and contact us, come to us, come with your questions that you have, including CDRH has a pre-submission program as well. It's voluntary, there are no user fees at this time. And we really encourage developers to come in as early as possible in the development journey to kind of, identify, is this regulated or not? Is this general wellness? Where does it fit in terms of the requirements you will have for your product?
Thanks, Arti. And Damien, anything to add from investor perspective in terms of the over-the-counter versus a regulated product in terms of the evaluation of those products or the considerations?
Yeah, I mean, over-the-counter is still regulated in certain cases, but in terms of reimbursable versus direct to consumer, with reimbursable, we think about three things. One is the experience of some participant improving because of this technology. So that could be the patient, it could be the caregiver, it could be the physician, it could be anyone else involved in the care pathway. The second is, are you improving health outcomes with the technology? And the third is, are you reducing total cost? So you're not spending $5 to save $1. So all of those things have to be true. When it comes to over-the-counter, you're really thinking about the experience of the purchaser, which is often the patient, but not always. And is the value of that experience greater than the value that they're going to have to pay out of pocket for it? And that's something that's very variable based on the technology and based on the time. A high-priced COVID test now in a world where everything is reopened has less value for a consumer than it did 2 years ago. But a technology like a life alert, for instance, for seniors, which is often paid out of pocket, has high value. So these things are dynamic, but you're really thinking about how much delight and utility or pain are you reducing for the consumer, and it's less about even health outcomes, although that could be important for some consumers.
Well, thank you. And it looks like we are at the top of the hour, so we're at time. I think we could have kept this conversation going, but hopefully we provided a perspective to think about considering the value of product and conducting these economic models early and considering the patient population, the setting, and a number of the factors and challenges brought up today. Hopefully will help developers in the future. But if you have any additional questions, I'm sure you can reach out to us and we'll try to get the panelists to address those. So thank you to the panelists. Greatly appreciate your time. I'll turn over to Dr. Selamovich.